We are Age-Wise Colorado, and we do a couple of webinars every month so that we can help educate you on various issues or things that are evolving, such as what's going on with Medicare, which we're doing today, along with a pharmacy program that is helpful in saving you money. Again, we're Age-Wise Colorado. We're here to work with you to help connect you to providers that will be helpful to you, and you know that they will be trustworthy providers. We vet them all and put them through quite a process so you know they're legitimate. So today we have Krista Keller, Connie Ward, and Alex Mathews, and Mathews is with one T. My apologies. I was just used to different spelling. You can read through these later on when you review this on our website. I do have phone numbers. I would also ask our presenters if you put those contact information in the chat. That would be helpful to anyone who may want to contact you after the webinar. And with
They
that,
can also find us on that beautiful website.
yes, Age-Wise Colorado, you're all on there. And I really appreciate all that the three of you do for the community of older adults. And with that, I am going to stop sharing and turn it over. Connie, are you starting, or Krista? I'm sorry.
Yeah, I'm going to start out. So,
Okay, thank you.
hi, everybody. Welcome. Thank you for joining us. Medicare is always changing, right? So my partner, Krista, and I have been in Medicare for a number of years, her longer than I, and I've been in for 15 years. So she should look older than me. So I don't know that this is exactly fair. But anyway, I'm going to start out the presentation by talking about the changes that are going on that are creating changes in Medicare plans. And then I'll turn it over to Krista to kind of talk about the differences between Medicare Advantage and Medicare Supplement. And then I think before we give it to Alex, we'll give a little kind of commercial on how to protect yourselves in this predatory sales environment that we find ourselves in right now. So I'll start out by talking about the changes going on in Medicare. There are three primary influences in the Medicare world that are causing changes in our plans today. The first is we're still living under the influence of the Inflation Reduction Act. So if you all remember, the Inflation Reduction Act was passed through Congress in 2022, and its first impact on Medicare occurred last year. And it did some really good things, right? It got rid of the coverage gap or the donut hole in prescription drug coverage that many people would find themselves in if they had over about $2,800 in prescription drug costs prior to last year. And then they'd be spending 25% on their medications in that coverage gap until they hit a soft maximum out of pocket of $8,000. So that all went away last year, and everybody had a hard cap of $2,000 for their prescription drug costs. Well, what that did at the same time is that Inflation Reduction Act defunded prescription drug coverage under Medicare, and it shifted the financial responsibility from the government to the insurance carriers. So when we all, as consumers, had a cap of $2,000 on our pharmaceutical costs, everything over $2,000 was now covered by the insurance carriers. And every single insurance carrier last year underestimated the impact of that financial shift. And so they're all making adjustments on their plans. For my clients who are on Medicare supplement plans with a Medicare prescription drug plan, the only way that they can adjust these plans is by increasing premium. So this last year, we saw an average increase of about 22% on Medicare supplement plans, and we're starting to see some changes coming for next year. Chris, I don't know if you saw this, Oregon, we just got Oregon United Healthcare up 25% on Medicare supplement plans. So we're seeing these plans increase in price. On prescription drug plans, we've seen the premiums on these plans double from 2025 to 2026. So the average premium this year was $44 a month. Next year, it's looking like it's well over $90. So That's the only way they can impact these plans. On Medicare Advantage plans, there's so many benefits embedded in these plans that insurance carriers can increase copays on a variety of different benefits without having significant impact to the consumer. And so you might be seeing that you're going to see higher copays on maybe specialist copays, outpatient surgery copays, and inpatient hospital are the three primary areas that we're seeing increases. But again, it's because of these increased costs to the insurance carriers. So two other influences that we're seeing on Medicare, one being the fact that we are an aging population. We have more people using Medicare than ever before. And at the same time, we have fewer people contributing to Medicare and Social Security taxes than ever before. We see that because there is a 62% labor participation rate right now in the United States. And you guys, what that means, that labor participation rate measures the people that are eligible to work between the ages of 16 and 65. And it shows us that 38% are not contributing to Medicare and Social Security taxes. To illustrate the impact of that, when Medicare first came around, we had 23 taxpayers to every one retiree. Today, that ratio is 2 taxpayers to every one retiree. So you can see that that's adding enormous financial strain on the Medicare system. The good news is Medicare is not going anywhere. We're going to have it. So kind of put your mind at ease there. But as consumers, we're going to be paying more for it. And you're kind of seeing that with your Medicare Part B going up next year. It looks like an 11.5% increase. So the base premium will be going up from $185 a month up to $206.50 a month for that Part B. They haven't formally come out and put the stamp of approval on there, but everything I'm seeing indicates that that's what the rate is going to be. So let's talk about the third influence on Medicare. It's kind of a strange one. So Medicare last year saw a 100% increase in specialist visits, which was kind of interesting, right? We might be able to attribute that to an aging population or to the fact that people might be more comfortable after COVID going to get care. But when Medicare went in and took a deep dive into that, what they learned was that specialist visits that occurred without a referral were oftentimes to the wrong type of specialist or for services not covered by Medicare. Here's 2 examples. I'm having a hard time breathing. Do I go to a pulmonologist or do I go to a cardiologist? It could be both, right? But if we're not medically trained, we don't know. And so a referral from a primary care physician is going to point us to the right place. Another common one was with orthopedics. So my knee's hurting really bad, so I go straight to an orthopedic specialist. But that orthopedic specialist, though he takes the fee for the service, he points me back to physical therapy and to start there, right? So there's been a lot of waste in the system. And what we're going to start seeing next year is prior authorizations and referrals for almost everybody in Medicare, even for folks on Medicare supplement plans for the first time. And I've already started seeing that starting in September with Common Spirit hospitals and Intermountain Health hospitals requiring these prior authorizations and referrals for specialist visits on Medicare supplement plans. So we're seeing a lot of change in Medicare, but hopefully this type of overview talking about what's happening globally might explain what you're seeing on your individual plans. So with that said, I'm going to turn it over to my good friend, Krista.
Well, thank you, Connie. That was such a good amount of information. I'm sure everybody on here is probably overwhelmed a bit by Medicare, and that's absolutely why people like Connie and I exist, is to help you navigate. I mean, things are changing in our world. We see it every day on the news, and I mean, this is just the one area specifically that we do focus on. And obviously, feel free to utilize all of us as resources, just because that is absolutely what we're here for. We want to make sure you not only understand, but also have somebody advocating for you to make sure that you're in the right place and that your coverage is serving you well, which is obviously maybe different than what your neighbor or your family members' needs are. I mean, your medication list, your doctors, all of that are going to be different from everybody else. And so we just want to make sure that you're doing what is going to be the right fit for you, which obviously can change from one year to the next. So with that, what I'll probably do, let me see if I can share my screen. I like visuals. So this is just a clarity, Medicare clarity guide. Can somebody give me a thumbs up if we can see that?
Got it.
Okay, perfect. Great. So, just a kind of Medicare 101, so to speak. How does everything fit together with Medicare? So, for those of you who are already on Medicare, you're probably familiar with this Medicare A and B. As a reminder, the Part A is the hospital coverage, and this is usually the one that comes at no cost because you've paid into this during your working years. The Medicare Part B, I know Connie mentioned this before. That is the one that does have the monthly premium, and that is what anything classified as outpatient services, so doctors, outpatient surgeries, etc., would fall under the Part B. We generally don't recommend just having Medicare A and B because there are a lot of things that Medicare itself doesn't cover with deductibles, coinsurance that may potentially end with having higher out-of-pocket costs for you as the beneficiary. An example of that under Medicare Part B is that there would be a 20% cost share. So let's say you were having a $50,000 outpatient surgery and you did not have any other coverage besides Medicare A and B. With a 20% cost share of $50,000, that's just like that $10,000 out of pocket. So obviously, none of us have $10,000 sitting around to pay for a surgery. So that's basically where the private health insurance companies come in to help with managing those costs. And we can do that in two different ways. And so that's what I'm going to show down here, option one and option two. So the first option is called a Medicare supplement or a Medigap plan. And conceptually, the way that this works is that Medicare is the primary insurance. Whatever Medicare doesn't cover, you can buy a gap plan to fill in that gap or to supplement what is not being covered by Medicare as a secondary insurance. So, for example, if you were to purchase a Medicare supplement plan that covers that 20% coinsurance for that Part B that we were just talking about, instead of you as the patient being billed that 20%, instead that they would bill that to your insurance company with the supplement. So it's really great setup with a supplement plan because you could end up with little to no out-of-pocket costs. So for people who are using their coverage more frequently, this is a wonderful setup because between your two policies, you're going to be very well covered. The premiums for the supplement generally run about $150 to $300 per month in premium. And the reason that I give that big of a range of premium cost is because it depends on which supplement plan you would choose. There actually are supplement plans that are much less than $150 a month in premium, but they may not have as much coverage. If you were looking at more of a Cadillac plan that would cover much more, again, you're going to be in a higher premium amount. And that premium generally will go up. It depends on what insurance company we were to choose, but between the cost of living and age, those are reasons that oftentimes those supplement premiums will increase. So if you're on a supplement plan now and you just got a notification from your insurance company that your premium has gone up, we're not surprised by that just because many of the insurance companies do rate you based off of your age. And they might say, as you get older, you would be more likely to use your insurance company, or I'm sure your insurance itself, because of health issues. Now, that's not always true necessary. That's just what a lot of the actuaries would say. So a lot of times that's why you will see, increases in premium. And of course, as we all know, the natural cost of living, which Connie covered much of that before. So again, there is going to be a monthly premium for that supplement plan and generally much less out of pocket costs when you're actually using it. So if you're a person that uses your coverage often, a supplement could be a really, really great choice for you because you're paying a monthly premium to your insurance company to make sure that your out of pocket costs are going to be much less when you're using it. With that, if we do go the Medicare supplement route, you will purchase your drug plan separately. So those premiums for the drug plan typically run anywhere. There are plans that are actually as low as 0 per month. And those do go up into the 100 a month range and sometimes even a bit higher. So again, it basically is just looking at what your medications that you're taking and then seeing what drug plan would match up best with your medication list to determine what the premium of your policy would be for your standalone drug plan. One last thing I did want to mention under this option one in general style program is that you will have to see doctors who accept Medicare because remember, Medicare is your primary insurance. So there are plenty of doctors in the Denver metro area that do accept Medicare. So if you were wanting a Medicare supplement, there are certainly doctors that you could choose from that do accept Medicare. There are also doctors throughout the country who accept Medicare. So sometimes people say, I would like to have some flexibility to see doctors outside of Colorado or wherever you are. And in which case, there are doctors all over the country that accept Medicare. So you do get a lot of flexibility in that regard. Jumping over to option 2, which is also called a Medicare Advantage or a Part C plan. Conceptually, what happens with a Medicare Advantage plan is that Medicare contracts with the private health insurance companies to become primary. So the insurance companies are paid a certain amount of money per member per month. All of that money goes into a big pool, and then the insurance companies decide what the benefits look like from there. So you may see out there, many of the private health insurance companies do offer 0 premium advantage plans or lower premium advantage plans, sometime even give back plans. And so when somebody comes to us and says, how do you have a 0 premium plan? How do you get something for nothing, right? You're not. So with the money that Medicare pays the insurance companies, that money goes into a big pool. And then the insurance companies from there, decide what the benefits look like and what they're able to offer to the consumer. So with being in a large metropolitan area, that reimbursement rate from Medicare to the insurance companies is generally large enough that the insurance companies do offer, again, low premium, in some cases, 0 premium plans, meaning that you do not have to pay anything extra monthly to the insurance company. And then what you will pay for are copays and coinsurances for medical procedures. So for example, maybe your plan, your Medicare Advantage plan says that you have a $25 copay when you go to the specialist. Or maybe your Advantage plan says you have a $150 copay if you had to go to the emergency room. And all of that is going to be laid out so you know exactly what to expect. If something happens and you have to have an emergency surgery, you're not frantically thinking, what is this going to cost me? Thousands and thousands of dollars? In most cases, not, because there's a flat copay per category. So for example, maybe your outpatient surgery copay is a $300 copay. So whether that is billed for $50,000, $5,000, or $70,000, your bottom line is you're paying a $300 copay, and the insurance company would pick up the remainder of that bill. So these plans do combine everything all together in one. So again, you do get your hospital, your medical, and your drug plan all bundled together into one program. So you just have your one card that you use at your doctor's office, your pharmacy. Many of the Advantage plans will also include extra benefits like vision and dental and hearing and things like that. And again, we can help you with navigating these options because, maybe it's a priority for you next year to have one of these benefits be added to your plan. Maybe right now you only have a couple of cleanings that are included with your dental plan with your Advantage. this year and you found out you need a couple of root canals for next year, we can help guide you into finding maybe let's bulk up that dental coverage. So again, that's just what you see all those ads on TV and everything for right now. Every plan does offer different benefits for specific reasons, and it's very hard to navigate through all of that. So obviously we can help with that. One last thing I just wanted to make sure that I mentioned on the Advantage plans is that you do have your network of doctors that you would access through the Advantage plan. So because the private health insurance company is the primary, that is who the doctors, facilities, pharmacies, etc., are all going to be billing. So an HMO plan means that you will stay in network with your doctors and you do not go out of network, generally speaking, except for emergency and urgent care situations. So a lot of times we're going to have insurance companies that do have pretty large networks of HMOs. So you do have a lot of doctors you would be able to access with that. Sometimes we'll see companies that do have a smaller network of HMO, and that's okay too. But we would just want to make sure if we were going to even consider that as an option for you, that all of your doctors are in network, especially if that's important for you to continue to see your doctors. So again, the HMO is where you stay within the network. And then there are also some insurance companies that offer what's called a PPO. So a PPO means that you can go in network or out of network. Generally, the in-network copay is going to be a smaller amount, and then the out-of-network copay is going to be a larger amount. So sometimes when people say, I need some flexibility, I have a doctor that doesn't bill in network with any insurances, but they will bill out of network, that would maybe trigger us to look at a PPO. Or sometimes there's going to be national network PPOs where you would have access to seeing doctors all over the country in or out of network under a PPO. So those would be reasons that we would maybe want to consider the PPO option instead of the HMO option. Again, this is kind of more high level information just to make sure you all have the information today. But this is kind of what we do when we're fine tuning and helping you choose your plan that's going to suit your needs, is to talk about all these priorities for you as far as your health care goes. So that was kind of the bulk of what I wanted to cover today, and I will go ahead and stop sharing my screen and turn it back. I don't know, Barbara, if you want to maybe interject at this
Yeah.
point.
I was just going to suggest, number one, we have a comment from Rick Martin about the ability to, when you get your Social Security statement, let me read this. Medicare insurance from your Social Security 1099 tax statement can be deductible along with your other medical expenses, if any, if you end up itemizing overtaking the standard deduction. And, you know, those of you that do that itemization probably are aware of this. Hopefully you're using someone to help you with that. You know, I'd like to take just a couple of minutes before we get into Alex's presentation about his program. Does anyone have any other questions per se for Connie about what's going on with the 2026, or Krista? You can unmute yourself and, oh, here we go. Med supplement. Oh, med supplements, this is from Alex, does not cover Part D copays, correct?
I'll go ahead and take that one since we were just talking about that. Great question to clarify on. The Medicare supplement is a medical policy, so it does not cover Part D prescriptions that are filled at the pharmacy. So those are two separate policies, and they don't have overlap. You either have things billed medically, either through the hospital or outpatient, which would be, you know, doctors, outpatients, surgery, emergency room, etc. That is all under medical, so that would be under the Medicare supplement. And then the Part D prescription drug plan plan all falls under the standalone prescription policy, and those would be anything that would be filled at the pharmacy.
And I guess I have a question. Is there an ultimate, maybe a lifetime cap in either of these kinds of plans, the supplement or the advantage? Or do you start over every year? So that if you needed a lot of major surgery and, I know I hear people who go into extraordinary debt because of their surgeries. That's my question. Is there a cap on that the next year, or could you start all over again if you
Krista, you
needed
want me to
another?
take it?
Yep, go ahead.
Okay, so first of all, if you're on a Medicare supplement plan, the most comprehensive ones, your cap is your premium, right? And your Part B deductible. So that would be your cap. If you're on a Medicare Advantage plan, your surgeries are going to be capped at the maximum out of pocket on those specific plans. And they all vary. Right now in 2026, the average max out of pocket is going to be $5,000 for medical. Okay, and you want to make sure you're staying in network so that you aren't exposing yourself to uncovered charges.
That makes sense. Thank you.
Yeah.
And I see that you've all put your contact information in the chat. Thank you. Alex, let's go ahead and hear what you have to share with us.
Sounds good. I'm going to share my screen here. Excuse me. I'm not as smart as Krista and Connie, so I need my PowerPoint to keep me on point. Let me know when you can see a screen.
There it is.
Perfect. So I'll be fairly brief. Again, my name's Alex Mathews. I'm a pharmacist living in Colorado, Littleton area. And we have a company called Medicare Pharmacist. It's essentially 4 folks. 2 of us are pharmacists, 2 IT professionals. And what we do is we take information from Medicare about the various plan designs, various drug databases, and then some information that a member might enter, like what specific plan they're on and what medications and pharmacies they use. Once we get that information, we're able to help design a strategy for you to save money. One thing I will mention is we are not, I don't work like Krista or Connie, and that I'm not advising you on a specific plan to choose. Once you have the plan in place, we work within that plan to help you save money. And then the other thing I'd like to point out is that a couple of things. One, we do not look to change your therapies. So we're looking to take advantage of the plan design, but we don't want to change the therapies that you've worked with your providers to be on. And then we also do not capture any specific, kind of PHI. We don't get your social security number, your Medicare ID, or even your plan ID. So we do this in a very anonymous fashion. Again, I'll save this, but again, I'm a pharmacist local here in Colorado. Our program is national, which is exciting for us. So I'll give you a little bit of basics about Medicare Part D, and then I'll talk about some specific saving strategies for you. So again, it's an optional plan. Obviously, most folks are enrolled in it. That helps pay for your outpatient prescription drugs. So you might have heard previously, there are medications that are covered under Part B as in boy. Part D is specific for the outpatient medications, again, administered through a private insurance company. And each of the plans are going to have their own specific formularies, which are going to identify which medications that they cover. And in terms of member responsibility, you're going to be responsible for a premium if there is one, and then your copay or your coinsurance. And then again, you can get Part D in one of those 2 ways, which were kind of discussed earlier. So in terms of what the Part D design looks like, you can see both the 2025 and the 2026 design here. You have a deductible in current year, you have a deductible of up to $590. And then your coverage, that initial coverage, you're paying 25% of the copay or of the drug cost. And then you hit that maximum out of pocket, the MOOP, at $2,000. And then at that point, you don't have any further patient responsibility. This is really what they call kind of the defined standard benefit. This is how it works out mathematically. The plans all have the ability to customize that kind of copay. So they're going to set individual drug tiers where you're going to pay, $5 for a tier 1 medication or 50% roughly for a tier 4 medication. So they've got some flexibility in how they design the plan, but mathematically, this is essentially what it works out to. The other thing I'm going to point out is this MOOP, this $2,000 in 2025, is not a straightforward calculation. So you can't look just at your calculated copays to come up with that $2,000. CMS actually provides you with the ability, or provides the plan the ability to credit you towards that $2,000 a higher amount without getting too detailed into the calculation. So needless to say, even though the maximum out of pocket is $2,000, if you hit catastrophic, you are likely to pay significantly less than $2,000. So I know that's somewhat convoluted, but that's kind of how the program works. Now, in terms of specific savings opportunities, this first one, we kind of break ours up into about 10 specific opportunities for members. This first one is for what we would call a high cost member. And essentially, because there is a maximum out of pocket, what we do is we look at your medications, we look at that maximum out of pocket calculation, and then we say, hey, is this member likely to hit that maximum out of pocket based on their specific plan? If they are, we provide you a strategy to get extra medication during the course of the year. So if you're on a high cost, let's say Ozempic, if we can get you 13 or 14 months worth of medication for the same price as 12, that saves you money going into the following year. So there's specific strategy that we would look at for those folks that are likely to hit that maximum out of pocket threshold. The other thing, another tactic, and this isn't a savings strategy per se, it would be called maximum out-of-pocket payment smoothing. So if you have an expensive medication that you're on, especially at the first of the year or early in the year, Medicare will allow you to spread out that copayment over the course of 12 months. And it's generally done by signing up with your health plan. So this, again, isn't a savings per se, but if it's difficult to pay for an expensive medication, if you have that deductible of $590 on January 1st, you can essentially take that, we'll call it $600, and spread that payment out over 12 months to an average of $50 a month, rather than having to come up with that significant out-of-pocket payment on January 1st. Biosimilars. So this is specific to Part B, as in boy. These are essentially generic drugs, but they're different than typical generics you might get at your pharmacy, in that it generally applies to specialty medications. And so based on the inputs you provide to us, we will look for biosimilar medications that are going to work identical to the original product that will save you money. And the rationale for this is the health plans, I'll just use Humira as an example, which a lot of folks have heard of. It's used for arthritis. You generally will pay 20% co-insurance for these Part B medications. So the original product might have a list price of $1,000. You'll have a copay of $200, 20%. The biosimilar drug might have a list price of $500, and you'll pay that same 20% coinsurance, so that your copay would be $100. The problem from a member perspective is both your provider and your payer, your health insurer, might prefer the brand name medication, primarily because they might get rebates on the product. So there's a kind of, it's disjointed between the incentives for both the patient and the payer. The payer might prefer the brand name medication in this circumstance. The patient would save money with the generic. And so we really look for those opportunities to move you to that generic where it makes sense for the member. Another thing we look at is Part B insulin. This was another positive change under the Inflation Reduction Act. Essentially, if you get your insulin through a pump, so under Part B as in boy, Medicare says you cannot be charged more than $35 in a single month for your insulin. So what that means is by just changing the timing of your fills, you can save yourself a $35 copay every 2 months. And that would, ultimately save you about $200 a year. So again, this is something our algorithm will look at. It'll look at your medications, how you're receiving that medication, and then provide the recommendation to you. And then one of the last ones, some of the last ones are lower dollar savings, but they're more widespread. We're going to look at where you're getting your prescriptions filled and see if there's an opportunity for you to save money by changing the site of dispense. So that could mean going from one retail pharmacy chain to a different one. It could mean going from a retail pharmacy to a mail order pharmacy, or we could be looking at going from a retail pharmacy to a pharmacy that waives copays for certain members. So sometimes certain low-income members can qualify for copay waivers, and our algorithm will look at your particular circumstances and see if you qualify if you move to a different pharmacy. We talked a little bit about OTC utilization, or Krista and Connie did. This is one of those supplemental benefits that a lot of Medicare Advantage plans offer. So we're going to look, essentially, we're not providing any detailed information, but we look at your plan, look at the specifics of that OTC utilization and say, hey, you've got a $50 per quarter credit that you need to make sure you use before the quarter is up. Otherwise, that might be a use it or lose it benefit. This one I'm not going to spend a lot of time on, but essentially we were looking at circumstances where an individual member might be able to save money on their prescription by virtue of signing up for a care management program at their health plan. And some health plans will offer this on specific medications for specific members. So our tool would look for that and see if you would qualify by virtue of signing up for a program. And then again, what we do is we do all that. So all this information is really available to you. If you want to do the legwork, you can do it. Our tool will do this for you for $25 per year maximum, and that's per calendar year. So it's against my own interest, but I would not suggest using our tool at this point in the year for 2025. I would wait till January 1st for 2026 to really see how your benefits are changing. Again, it's going to cost you $25 for the year, but you can come in at any time. You can go in, change your medications, change your pharmacies, all of that information. And again, we're not going to collect any of your information up front. I do have a demo, but I think in the interest of time, I'm not going to share that, but that's essentially how our tool works. And now with that, I'll turn it back over to Barbara.
Thank you, Alex. I keep clicking. There we go. Thank you, and I appreciate all that information. Tell me, what are tiers? I know a lot of people ask that question, and any and all of you can answer it. The tiers of medication.
Essentially, there's generally a 5-tier formulary. Sometimes it could be different. There can be 6, but as a general rule, there are 5 tiers. And tiers 1 and 2 are generally the low-cost generic medications, and they'll be associated with those lower copays, $0 up to maybe 15. Tiers 3 and 4 are going to be brand name medications. Tier 3 is what they would call preferred brand, and tier 4 is going to be non-preferred brand. And the tier 3 copays generally range in that $30 to $50 per month. And the tier 4 copays generally are associated with coinsurance. So if a drug costs $200 cash price, the tier 4 medication might cost you $100. And then tier 5 is the specialty medications. Excuse me. And again, those are associated with coinsurance versus copay as a general rule.
Thank you.
Mhm.
Next question. How do the insurance companies calculate the MOP? Meaning, first, are you required to pay the deductible, like the $590? And then once you pay that, the drug cost exceeds $14.10, all drugs are free.
So and it's the MOOP. It
MOOP,
is,
I'm
yeah,
sorry,
that's
the
okay.
MOP.
I the MOP. MOOP is
Mopping up.
MOOP is basically calculated and so it gets kind of tough for a member to know. If you've got I'll just use round numbers. If you've got $1,000 drug, say the cash price was $1,000, and let's just for the sake of argument say your copay is set at $50. The MOOP is calculated as 25%. It takes the greater of 25% of the cost of the medication or what your copay as filed on your benefit is. So that $1,000 drug, 25% would be $250. And or your $50 copay. So you pay $50 out of pocket, but what counts towards your MOOP is $250. It takes the greater of. The deductible, if you're paying the cash price on the deductible, that $590, that would count towards your MOOP as a general rule. That would count towards that $2,000, and then you would pay that $14.10 going forward. Hope that made sense. It's a complicated kind of calculation, but the general rule is it's good for the member. You generally are going to pay less than the $2,000 out of pocket than what the MOOP is.
And can you tell us what a care management plan is?
So essentially, the drugs you see it most frequently are like COPD inhalers or anticoagulants, sometimes in diabetes as well. But essentially what they're looking to do is if they're going to pay a fair amount of money for an expensive medication, right? If you think about some of these anticoagulants or COPD inhalers, they cost about $500 a month. And so what the plans were doing was if you signed up for the care management plan, they would waive those copays. And essentially what the care management plan was making sure that you're taking your medication appropriately. So they want to make sure, hey, if we're going to pay this medication, we want you to be counseled on how to use the medication appropriately. A lot of those programs have gone away for 2025 and 2026, although they are there in some limited fashion. But yeah, that's essentially what it is. You're talking to a healthcare professional, a pharmacist or a nurse, and they're going to walk you through how you're using your medication to make sure the health plan is getting some benefit for paying for that medication.
And is that tiered with Part D then?
Is that tiered with Part D?
Yeah.
So yeah, it's with the Part D medications, but again, a lot of that's kind of phased out over the last couple of years because CMS has made some additional requirements. Again, they still do exist, but it's pretty small.
And just to tell you, someone commented, Alex, that $25 a calendar year seems like a terrific value to ascertain savings opportunities for any senior with prescriptions. And I would absolutely agree with that statement.
Yeah, I'll tell you, we're really, so we market this directly to providers and to patients. And the patient side of it is we're just trying to cover our costs, quite frankly. We're trying to, we're trying to make our profit on marketing it directly to the providers. So we're basically giving it away at cost.
Yeah, we normally don't have someone like you on our webinars that literally is promoting a program. But this is such a dynamic program, I think, that can help so many people in our state, and especially with all that's going on these days, we're all counting pennies. Oh, wait, we don't have pennies anymore, do we?
That's
We're
right.
counting nickels. Let's see, I've got another. How do you find out when you qualify for a care management plan?
So you'd have to look at your specific plan and your plan documents, basically. So that's what we try to do for you. Again, the care management and that portion, I would just caution that is going to be fairly limited. Most patients and plans don't have that going forward. So I would not, recommend you spend a lot of time trying to locate that, but it's specific to your plan, your medication, your disease state.
Got it. I guess I have another, I'm gonna turn your screen sharing off, and this is probably a Connie or Krista, but it doesn't sound like it's an Alex question. It sounds to me like determining what, if you were going for a Part D plan, figuring out what Part D plan to choose sounds a bit complex. Is that something that people that do the work that you do would help, a potential client?
Yeah, Krista, I think I can speak for both of us. Of course, we would help. There's also a good resource on Medicare.gov that everybody can access. And if you go to Medicare.gov and you can hit Find Plans up in the upper right-hand corner. And when you click on Find Plans, you're going to be looking specifically for prescription drug plans. And you enter in all of your medications, and it's going to list the plans that are best for those medications in order of annual cost. And it's a really good way just to kind of go in and pay close attention to the total annual cost, because that's going to be your premiums and your copays combined along with your deductible. But yes,
I
both Krista
kinda
and I
knew-
can help with that also.
I knew the answer, but I had to ask because I've gone in and initially was concerned about, oh, how do you do this? And is it going to be clear? And it really was. And it identified the pharmacies that were near me that would accept this plan, what it would cost me, and actually different pharmacies charge different amounts. So that's where Alex comes in.
Right.
Does
Good
anyone
questions.
else? Does anyone else have questions? We have a latecomer there. If we don't have any questions, I would thank you all so much. All of our presenters have put their contact information in the chat bot. If you want to take a moment to check them out, copy them down. Again, you can also find all of them on our AgeWise site with their websites and their phone numbers, so you can call them. And thank you. I know it's a very busy time for you, so thank you for taking the time with us.
Absolutely. Thank you.
Thank you.
Thanks,
Thanks
everyone.
all.